We have developed Ladder, a patented drug repurposing platform that can deliver new therapies 200 times cheaper, 9 times more likely to succeed, and 4 times faster than traditional development. Taxol is an example of how one generic drug can be used to treat multiple types of cancer. There are other examples of how existing drugs can be used to treat more than one disease, but these are largely still the exception. Widespread repurposing remains limited due to challenges around costs and economic viability that bottleneck investment, impacting the number and availability of affordable treatment options for known diseases. With Ladder, we can change that, transforming generics into new therapeutics, addressing challenges of economic viability, while keeping the cost, risk, and time advantages of repurposing. This removes the investment barrier and directly accelerates availability and affordability of safe and effective treatment options. We have already demonstrated 6 successful repurposing in the US. Now we are developing the first ever oral Taxol, turning an intravenous cancer therapy that is difficult and costly for many into a capsule that is easier to take and more affordable for patients worldwide. We are also creating a non-burning capsaicin for diabetic neuropathy, unlocking relief for millions who suffer from diabetes.
Hi, I'm Bill Ewan. I've worked in the patent space for nearly 2 decades and have seen many remarkable technologies. That said, nothing compares to what Sandeep has built. Its potential for real social impact is extraordinary. That's why BCAM Health is making a commitment to action and working with the Clinton Global Initiative to help close the global health equity gap. But we can't do this alone. And so we invite you to join us, because together we can make affordable, effective treatments a reality for patients everywhere. Thank you.
Please welcome to the stage Dr. Tom Frieden, Dr. Jackie Gerhardt, and Dr. Githinji Gitahi.
Well, thank you all for being with us, and it's just really wonderful to share space with some people that I've known for a very long time and some I just met backstage. I think, you know, as we have heard so kind of frequently today, and as no doubt is being echoed, you know, across different meetings in this city and really around the world, we're at, you know, such a critical moment, both in trying to kind of preserve the gains that we've made in infectious diseases and try to finally make the gains that we know that science should enable us to do when it comes to non-communicable diseases. And I am going to start with the person I know best on the panel, the man sitting to my left. You know, Tom, you worked, you know, in local public health departments. You led the CDC. You've worked now in different arenas focused on, at times, like one NCD and others like risk factors for NCDs. Can you tell us kind of what you're doing now with Resolve to Save Lives? And if we could coalesce around a few priorities, kind of what would those be?
We work in partnerships with communities and countries to scale up solutions to the world's deadliest problems. Treatment of hypertension, high lipids, it's in such a different place from the infectious disease world. With so much leadership, so much commitment, so much advocacy, we see access to antiretroviral drugs. On the other hand, 1 billion people in the world aren't treated with simple, generic, effective, safe medications that can cost $5 a year and prevent many of the 11 million deaths that happen from uncontrolled hypertension every year. It's possible to change that. To change that with a focus on learning from the infectious disease programs, standardized diagnosis, standardized treatment, standardized monitoring, ensuring free care. We don't charge for anti-tuberculosis treatment because that doesn't work. But if we insist that patients pay for treatment for their hypertension or their high lipids, we can't get the kind of high control rates that will prevent so many heart attacks and strokes. So we partner with countries to scale up solutions to the world's deadliest problems, and we also work on primordial prevention or primary prevention. We've worked with more than 50 countries to pass bans on a toxic substance, artificial trans fat. We did this in New York City, we did it in the US, and then we joined with the World Health Organization, a very important entity, to call for the global elimination of artificial trans fat. And since that, 4 billion people are now protected. Wow. 9 million people won't die from heart attacks. Not one of them will know it. But the world will be healthier because of this global partnership.
We now know it. Jackie, we heard like the very large numbers that Tom just cited. We know that more than 72% of deaths annually are caused by non-communicable diseases. We know that more than 41 million people die of NCDs every year. Probably at least a third, if not more, of those are people who are considered to have died prematurely, that if they were able to access both the specific intervention and kind of the larger basket of interventions that Tom referenced, those people could and should be alive. How does Epic think about your responsibility in all of this? I mean, you have, I believe it's more than 300 million patients that are in some ways connected to the Epic system. How do you think about your responsibility, and what do you think the opportunity is here?
Yeah, great, thank you. So I'm a family medicine provider at heart, and so chronic disease and closing care gaps is deeply on my mind at all times. At Epic, really the goal is to try to help care providers and patients be able to remain well and stay well throughout their life, to really have a joyous and happy life that they want to live. And it's really about wanting to create a story around that patient, starting by putting the patient at the center and all of the information about that patient and their family together in one location so that you can then learn from that. And then, both for that individual and for the populations of individuals, use that data to help advance medicine. So the responsibility started out as being an interface between a clinician and a patient, and now it's very much used specifically by patients in the form of MyChart. Raise your hand if you've heard of MyChart before. So quite a few, and I think that's one of the biggest opportunities we have to bring healthcare directly into the pocket of people throughout the globe and be able to connect them not only to their care, but also to their family's care, and then furthermore, be able to educate them, because really that is an empowerment for them, that they don't necessarily have to come to me as a physician, since we're so in such short supply and we have such great demand. How can we really empower physicians and our patients to be able to understand their health and what they can do with their data to be able to really empower their care?
And to then have more evidence-based conversations, including their own health data, conversations in their family about what different choices maybe the family should make, or how to ask more acute and specific questions of their care providers. Githinji, I want you, please, if you would, to share what you're doing with AMREF Health Africa, kind of how you're working to help better identify NCDs earlier, and such that earlier identification can lead to earlier intervention, and how you two, similar to what Tom was saying, are working to help scale up what we know works.
Yeah, thank you, Chelsea. And it's important first for the audience to understand that NCDs are a real problem in low, middle income countries, a real challenge. I think for the longest, we've kind of focused on communicable diseases, which are important. There's still a lot of unfinished business on them. But we are now seeing that in a typical country in Africa, 50% of all hospital admissions are non-communicable diseases. They're cancer, hypertension, diabetes. That was not the case before. And 37% of the deaths are actually non-communicable diseases. This speaks to an urbanization transition, a nutrition transition, with people consuming more of what they consider prosperity foods, which are westernized foods. And therefore, they think that their traditional foods are backward and they need to move forward. And number two speaks to the absence of regulation. Speaks to the absence of regulation in that those fast foods, or what the people call westernized foods, come with a different market environment and apply different standards and quality standards in the low middle income countries from what they apply from their source countries, especially the fast foods. So what we are seeing is that we have a major challenge, number one, with late diagnosis, because we do not have systems to begin with at the health system that were built for non-communicable diseases or chronic diseases. So if you go to a clinic in any African country and you have hypertension, you'll be surprised that every single visit you go is actually a different visit. There is no chronic care continuum because that was not our health system. It was not like that. So the first thing we have to do is work with the health system to ensure that we can actually take care of chronic care. The next thing that we have to do is to ask about the costs of care. So we are working with the governments to ensure that care for non-communicable diseases is embedded in the national insurance systems, because if you look at many, you look at Chad, Malawi, Zambia, Kenya, Uganda, the communicable diseases are overwhelmingly taken care of by the global health system, by Global Fund, by Gavi. Of course, now that's threatened, as we know, and it's also threatened by a lot of misinformation. I just want to say acetaminophen is safe.
Danji, I think you might be the first person really who's ever brought a prop. And I just want to say that I really appreciate that you brought a prop, and specifically that one.
Yeah, acetaminophen is safe, isn't it? Yeah. So misinformation is a big problem for this. So we have to provide the information that is needed. But let me conclude by saying that the biggest challenge that we have for us as an organization working with communities and governments is the future health system. We built a system that is based on communicable diseases, that is heavily funded by the global health system, and non-communicable diseases are 80% funded out of pocket by families. And that is what worries us. Actually, my own view is that the health system is going to collapse because of non-communicable diseases. So what are we doing, Chelsea? We are trying to downstage the diagnosis. We are working to downstage the diagnosis, that people should know they have hypertension early enough, they should know they have diabetes early enough, so that we don't offer them dialysis. We offer them the prevention for their dialysis. And to do this, we are using communities. So community health workers with a mobile phone in their hands, with a glucometer in their backpack, with a blood pressure machine in their backpack, visiting households every day. A community health worker visits 100 households. They will tell you who has hypertension, who has diabetes. Then we link them to the care clinic in the hospital. But eventually it's about downstaging. But finally it's about policy and regulation. That we must not only focus on treating the disease, we must focus on health production. How do we ensure that the people actually don't get there? We have to work on those factors that are increasing obesity in Africa, that are increasing these cardiometabolic diseases in Africa. That talks about food regulation, food processes, and that speaks about education of communities based on community health systems and starting as household.
Githinji, while you were speaking, I had two thoughts. One, I wish that we had that here in the United States. I wish that we had a robust network of community healthcare workers that could extend the family medicine practice. And two, just the enormous clarity around kind of what is needed to build a system, whether thinking about kind of, as you mentioned, regulation, kind of private sector capacity, and thinking really about how the public and the private sector, in an ideal state at least, would work in concert together. And so, Tom, I then want to ask you, as someone who, from here in New York City, when you were our healthcare commissioner, to again at the CDC, or I know now so much of the work that you kind of advocate for in your current role with Resolve, how do you think about, in this moment of decreasing resources, increasing need, and also to then kind of turn to Jackie, kind of at least the promise of what data should be able to facilitate and empower for people? How do you think about all that together?
So we have partnered with more than 40 countries to support the improved care of more than 40 million patients with hypertension and or diabetes. And these countries have led, they've implemented programs that work. We've identified—
Found the space in their budgets to pay for it.
They have. I think one of the things that we have to do is increase resources, and health taxes on tobacco, alcohol, sugary drinks, and unhealthy foods are the best way to do that. But they're not going to fill the whole gap, but they're the best thing you can do to reduce non-communicable diseases. In addition, they'll reduce healthcare costs and have healthier people. That's the most important. But what we find in the healthcare system is exactly as Gitanji is saying, we're not created for the current challenges. A concept that I think is very powerful is progressive universalism. And that says we're going to start with the services that will save the most lives, do the most good, for the individuals who will benefit the most. And we're committed to providing everything we can to as many people as we can. But if we pretend that we're providing everything to everyone now, we're not going to do as much good as we can.
We won't have the credibility or trust that is a necessary ingredient.
And we've started with people with high blood pressure and diabetes because this accounts for a huge proportion of the preventable heart attack, strokes, dialysis, dementia, and death. And the treatment is low cost, it's effective, it's safe, it's generic, it can be less than $5 a year, it can be delivered by community health workers and clinical officers, it doesn't need to be doctors or registered nurses. Many countries have teams that do this. The two major gaps that we see in the lower income countries, one is medications. Even though it's only $5 a year per patient, it's millions and millions of patients. And so we're seeing a huge gap, and no one has come forward to fill that gap. That's a big challenge. We would never have gotten the success we've gotten in tuberculosis, malaria, or HIV if we made patients pay for the medications. So we can do more with efficient procurement to get the costs down, but still, you have to try to make the cost for patients zero, because hypertension is the silent killer. With every beat of patient's heart, it's damaging their heart, their brain, their lungs, their coronary arteries, and that silence is deadly. Now, the other major gap is exactly as you say, information. And what we see here, if I can be really frank, is we see a bad collision of many leaders in countries think that digital is going to be great, just like email. It's going to be cheap, easy, and free, and fast. And many companies, for-profit and non-for-profit, say, yes, yes. And so I lost count at about 18, the number of countries I was in where I was told, we're going to have a great digital system. Come back in 6 months or a year and see it. And not one of them has developed that system. Something like Epic is a great system. It took many, many years to do that. And so what we really urge when it comes to digital innovation is to be user-centric, not just in name, but in fact. We did this with a digital innovation that works well in places with it's open source, it's free, it works well when there's no connectivity, offline first, secure data. It takes healthcare workers 13 seconds, this is based on metadata with more than 1 million patients, to enter the follow-up information, about a minute to register a new patient. Countries like Bangladesh have tripled control rates, empowering healthcare workers to know who didn't come back, to remind them automatically with text messages, to facilitate with one-tap calls, or sending a list to the community health worker to go bring them back. That kind of a system is powerful, and we're now working with as many countries as possible to incorporate the lessons of that system, which is called simple.org, into as many different platforms as possible. We've done it with DHIS2, which is the most widely used system out of the University of Oslo, used in more than 70 countries. But these are the two barriers, medicines and information, and for both of them, this concept of progressive universalism. Which medicines are most life-saving? You may say family planning, you may say hypertension, malaria, whatever a country decides. There's a list of 500 medications on the essential medicines list. 35 of them probably can account for a great majority of the benefit and cost maybe $4 per person per year. So it's achievable, but only with prioritization. And the same on data. You try to collect everything, you're not going to collect anything well. And so prioritizing only the essential data, the most important systems, and then progressively do more.
You know, Jackie, I want you to respond on the data point, if you will, and also reflect on something that I was really thinking about while Tom was speaking, is that so often, particularly I think in healthcare, innovation is treated as like whatever the bright, shiny thing that AI, may enable. But sometimes innovation is actually just like good old-fashioned logistics innovation or good old-fashioned problem-solving innovation to ensure kind of the outcomes that Tom just spoke about in the countries where they're working, could be possible anywhere. So, how do you reflect on what Tom was saying, but also how do you think about Epic's responsibility to support the most important central kind of data collection in a way that is usable, safe, protected, while also worrying about whatever the future with AI could or should be?
Sure, that's a large question, so I'll break that one down. So at Epic, in every bathroom, break room, we have 2 signs, and they're almost like 10 commandments of corporate philosophy. And one of the very first ones is software must work, period. That's it. It's not innovate, it's not, come up with a shiny object, it's not think about, the next 5 different things that you could do in the world to try to improve IT. It's actually not even necessarily IT-centric. The software must work means work for the user. That could be the patient, that could be the community health worker, that could be the provider. And so the idea really is go to where that care is happening. Go into the home if it's home health. Go to a hospital if it's surgical care, let's say. And every developer, we're a development shop. We are mostly developers at our core. There's only 13 physicians on staff, so we have a strong and mighty role there. And the goal is to have them literally be elbow to elbow with the people that are using the software to make sure it works. And I completely agree with the idea of a shiny object. The first question you should ask whenever you're trying to implement a new technology isn't, what is the technology? Or even, what does the technology do? But rather, what is the problem I need to fix in my healthcare organization, in my community, with my patient's care, that then I can figure out perhaps a solution that has some technicality to it, but is it maybe a people problem? Is it a workflow problem? What are we actually solving for? And so really the bigger picture of healthcare, of how the software and the IT and the digital health works within the existing workflows is the key. It's not replacing the workflows in any way. From the data perspective, I think it'll be great when we start thinking of data instead of the exhaust of healthcare to be the fuel of healthcare. And it used to be that data itself wasn't really the innovation, it was just the byproduct of whatever I would do in a clinic or what we would actually put down on paper or in an electronic record. Now really that's the promise of how we can make advanced medicine, make cures. We're working, speaking of diagnosis, we're working on using AI and real-world evidence, something called Diagnosis Advisor, which I think is going to be amazing. It essentially takes, in people like me that are my age and similar comorbidities, et cetera, if the doctor is lost and doesn't know what that patient has or is confused, or maybe it's a medical mystery, that they can put in that information and then compare it to hundreds of millions of patients throughout the world and try to figure out what were they diagnosed with? What were they treated with that worked? How can we actually decrease the diagnostic odyssey in the therapeutic journey for these patients with either rare diseases or something common that I just might not have thought of? And the beauty of using AI to help augment my clinical reasoning and my ability to then put forth my humanism in medicine and have some of the friction go to the wayside is really what I think is going to advance care in the future.
Githinji, I want to give you the last word. What do you kind of think are the necessary ingredients, whether like partnerships, kind of public sector shifts, entrepreneurial, like whatever you think the right ingredients are to ensure that if we're on this stage and say, 2 or 3 years, not like 2 or 3 months, but 2 or 3 years, that the picture that you shared of kind of how hard it is to have kind of early diagnosis of NCDs across sub-Saharan Africa has changed. Like, what are the big levers that need to be pulled, and how can we here try to help you do that?
Thanks for the pressure of the last word. And I think it's about what has been said here, that solutions have to be offline first, bottom up. Meaning you go to where the problem is, you work with the community, and you identify what the challenges are. I have had, for example, a lot of people generate tools for vaccination reminders, AI, and this kind of thing. But the most important device I found in a clinic was actually an on-shelf box that shifted cards of children who are vaccinated. If you're vaccinated on Monday, then it's moved to Tuesday for the next, it's the most effective. And I talk to the nurses, they're like, we love this thing. The other thing, my mother has chronic diseases, and she uses a pill box. She doesn't use a smart app on her phone to remind her. She uses a pill box. Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday, then goes back. So I think that concept is important. The second thing is trust. I think we have to trust each other. And the challenge that I find is that the trust is being broken through misinformation. I have had, people of chronic care are the most hopeless people in the continent. I can tell you, chronic disease and poverty are both large causes of hopelessness. So those people are vulnerable to misinformation. I've had videos done of me talking about discovering treatment for arthritis, discovering treatment for hypertension, and those videos are done through AI. It's a video of me speaking to you now, but the audio is altered. And that is actually one of the biggest challenges that we are going to have with chronic care patients. So we must also think about how to use AI and use it ethically, and how to actually overcome the misinformation, and that's why I'll still end up with this, that misinformation kills, and we must build trust, because trust is what is going to get us where we want to be. And the first trust must be built to the community. Thank you.
Well, Gitanji, Jackie, Tom, thank you all so much. We're so grateful to have trusted experts and leaders on the front lines trying to help keep all of us healthier. Please give our panelists a round of applause. Thank you all.
Please welcome to the stage Dr. Chelsea Clinton, Daniel O'Day, and Peter Sands.
Thank you. It's always wonderful to share space with my friend Peter and also with Daniel, whom I've been lucky enough to already spend time with today, and I think to whom all of us at Global Health are just incredibly grateful for his truly kind of paradigmatic leadership, proving kind of what's possible when inertia is discarded and where the past is prelude but not precedent. So I hope we can maybe spend this time together talking about kind of all of the news around lenacapavir, but really kind of in the cadence of the long calendar to get us to this moment. And so I wonder, Daniel, if you could just kind of initially set the stage for us about kind of 17 years ago to today, and kind of why you thought it was in Gilead's corporate interest and not only moral interest to make the decisions that you've made over the last couple of years.
Absolutely. Let me start, Chelsea, by thanking you and Chai for the incredible announcement you made today. This will save millions of lives, and it's one of the things I want to speak about, because as much as I'm proud of what Gilead does, I know in this audience and on this panel, it takes an ecosystem to think about ending a disease. And so I'd just like to briefly comment on that ecosystem. It's overly simplified. It's an innovator, a private sector innovator. It's donors, both public and private. And then it's obviously the governments at the end of the day that implement these programs. So what is our role as an innovator? And back to your point, I mean, Gilead, I have the privilege of representing the scientists and the people I work with, just to be clear. They have been at HIV for more than 2 decades now, and they've come up with really brilliant innovations over that period of time in both prevention and treatment to turn HIV from a death sentence to a chronic preventable disease. I just want to put that in the context of lenacapavir, which, to your point, despite that tremendous innovation, lenacapavir is a step change. It's an absolute step change in our ability to end the epidemic, not by our own, evaluation, but by global public health officials. It was our role to come up with something that was going to make that step change. And our scientists spent 17 years really working on a target that was actually came out of the University of Utah and some of the basic research there, which talks about the ecosystem here in the United States, but it was thought to be undruggable. We use the word grit with our scientists. They literally make it their life's work to end HIV. And they worked at this target for 17 years to find this unicorn of a molecule, which is a small molecule that not only in the first trial that was done, and that's also part of our thinking back to the fact that we have 1.3 million cases of HIV in this country, but there's 40 million cases around the globe. So if we don't think about what the needs are of the people in the developing world when we pursue our medicines, we'll never end this epidemic. And back to why that's a benefit to us, because you can't end a disease, infectious diseases, if you don't end it everywhere, you don't end it anywhere. So 17 years in the making, unicorn of a molecule. The first study was done in sub-Saharan Africa amongst adolescent girls and women, basically, age 16 to 24, which is 2/3 of the new cases of HIV in the continent today. And it showed to be 100% effective at preventing HIV with a twice-a-year subcutaneous dose. It was actually incredible to see the scientific community, give a standing ovation. They said they didn't think that'd be possible. And that's the beginning, right? It's only good if we get into people's hands. So there's 2 other things we, as the private entity, did. We immediately voluntarily licensed the product. Of course, we were the first to ever voluntarily license an antiretroviral drug 20 years ago, but never this early and never with this much speed and scale. So we went to 6 voluntary licensees and a royalty-free basis. We technology transferred before we even filed the product. And that piece of the puzzle is what I'm so impressed by what Chai is going to do to support those generic manufacturers to get to scale quickly. But the second piece of the puzzle was, regardless of how quickly we could move, we knew a generic manufacturer wouldn't invest until they saw the clinical data. We had a gap period of 1.5 to 2 years where we had to work with other donors like the Global Fund and Peter, who had the vision to get this medicine to more than 2 million people before generic manufacturers. And again, part of our corporate responsibility was to say, we will manufacture that at risk so it's ready to go to 2 million people. And this is a no-profit price for the Global Fund, and now we're also pleased that PEPFAR will be involved in helping again, too. So that's extraordinary, because when we think about catalytic kind of differences, all of those pieces are necessary. You need the innovation, you need donors that support the catalytic start of the medicine, and getting up to 2 million people before the generics ever go out the door gives the generics the ability to bring the price down to the level that, thank you, that you were able to get them to, because they know there'll be a market there for them. And at the end of the day, what this also does is it supports global donors to, over time, spend less money on this disease and more on other diseases. We want to get to that stage, and I do believe we will in our lifetime see an ability to get that 1.3 million new infections down significantly to a level that we can imagine an AIDS-free world during our lifetime.
Peter, I wonder if you can kind of share the complement to what we just heard from Dan as to how, even in a moment of kind of resource retrenchment, right? We know that official development assistance is down more than 20% just in the last few years. Global health has been hit kind of disproportionately hard in that, partly because global health had disproportionately been represented, in particularly kind of the upsurge of funding, which really, I think, exemplified kind of what Dan was talking about. As more became possible, more bilateral donors, more philanthropic donors, but particularly more bilateral donors especially, although not only the United States felt compelled to ensure that first and second line antiretrovirals, kind of better point of care diagnostics, kind of better treatments for kind of the constituent diseases of the Global Fund, kind of reach people more quickly, more efficiently, more effectively, kind of than ever had been possible. And yet, we're in this place where we are both trying to ensure that that progress is not precarious, that it is protected, that the 1.3 million people that are newly infected every year also are able to access the medicines that we believe everyone should be able to have to render HIV a chronic disease and not a death sentence, and have the resources and the systems in place to better protect people, especially women and girls, from infections in the future. So I said a lot of words, but what I'm really asking you is how do we both walk and chew gum at the same time when we're on arguably a upward slanting, backward escalator?
Yes. I want to start in going back even further to when the Global Fund was created, which was, 23 years ago. And one of the prime motivations of the leaders who created the Global Fund was to get antiretrovirals out to people, because we had this horrible situation where antiretrovirals were available in the rich countries in the world, and they were simply not available in the places where most of HIV/AIDS was, and as a result, millions of people were dying. And, part of it was price. $10,000 a person per year was the cost of antiretroviral treatment back in 2002.
And Peter, fast forward, what is it today?
It's about $35 per person. So it's massive increase. And we've got about, we're in various ways involved in keeping 26 million people on antiretroviral treatment. And that's out of a total in the world of about 31 million. But there are 40 million people who are HIV positive. So there are about 9 million people who aren't on treatment. But when we look at it in this big picture, the problem is that we're still adding 1.3 million a year. And although treatment is prevention because people who are virally suppressed do not pass on the virus, the fact that we're still at 1.3 million people means that we haven't, in a sense, got ahead of the problem. And so when we first started looking, and we always keep an eye on the pipeline of products come down, and as this started looking as if it was going to be real, we started getting really excited about the fact that this might be the thing that enabled us to really sort of step up the game on HIV prevention. And then the trials came out, and we were like, whoa, this is really something. And we got to get really serious about it. And so we had lots of conversations with Gilead, and we were having conversations with PEPFAR and WHO and so on about it. And we came up with this notion that as a start, we should aim to get it to 2 million people as quickly as possible. And obviously, the 2 million people who are most at risk. And why 2 million? I wouldn't promise that it was the most scientific number. It was a big number we wanted to go for. Actually, we think that the population who could benefit from this is probably more in the 8 to 10. But 2 million seemed like a reasonable aspiration for a number we could go to quite fast. We wanted to get big enough that we weren't just having an individual benefit of protecting people, but we were having a broader public health benefit because we were protecting high-risk populations. As you say, it's been an interesting year. And it's been a year in which funding for HIV, look, 95% of external funding in low and middle income countries for HIV comes from either PEPFAR or the Global Fund. And so there aren't a lot of other alternatives. And as the year unfolded, I got a lot of questions about, so if you're on your own, are you still going for the 2 million people, or is the 2 million now a smaller number? and we decided that we were just going to kind of go for it. And we were either going to do it all ourselves, or we were just going to go for it. Because our view was that kind of history will not look kindly on us if we don't seize this amazing opportunity. And the faster we seize it, the more lives we will save. So we ended up working a lot with Dan and his team to do a global access arrangement for the branded product. Because although the generics are a couple of years down the road, that couple of years is a lot of people. That's a lot of people. And also what we knew is that the price point at which the generics would come in would also be a function of the size of the market they were coming into. And the more that we could build that market rapidly, the more attractive it would be for them. And so, I mean, it's been a great partnership. We've got the US government is now, they announced just a couple of weeks ago that they're working alongside us to roll this out. We have lots of intense conversations going on with individual countries about launch planning. It is important to emphasize that this isn't going to be just something that you kind of do on its own, right? It's going to be integrated with testing programs, enrollment onto treatment, and also prevention alternatives, because although it's a fabulous product, it won't be the right prevention tool for everyone. And so we need to make sure it's used in the most appropriate way. So there's a lot of work going on. And the thing that really excites me is this is the first time I think we've had an HIV tool of significance rolled out at the same time in low middle-income countries and high-income countries at scale. It's an opportunity to accelerate the end of what actually is, I mean, we all have COVID fresh in our memories, but the largest pandemic in the lifetimes of many of us actually is HIV. It's killed over 40 million people thus far. If we could bring this effectively to an end, not to eliminate or eradicate, but as a public health threat within a relatively short period of time, I mean, who wouldn't be excited about that? That's an extraordinary thing to be a part of. And the thing is that what we have found is that it's not just about the product itself, and the product is brilliant, but it's about giving people new kind of hope and energy about, people were a bit battle weary in the fight against HIV. And this has given people a real sense of, oh, wow, we can win. And that's fantastic.
Yes, please. I think certainly, Peter and Dan, we saw the announcement that we made on stage earlier, really thanks to the extraordinary people at CHI who also have been working on this tirelessly since kind of there was the first whisper of this new science that, I think, Dan, your team weren't the only ones who believed this might be impossible. And really working in partnership from the beginning with not only ministers of health, but ministers of finance in kind of all the countries in which we kind of work and operate. And Dan, in an earlier conversation, it was also deeply heartening, though not surprising, to hear about all the work that your team is doing to ensure there's regulatory approval in all the countries where you will be kind of working with the Global Fund and CIF and others to help kind of scale up production. I wonder, though, in the last few minutes, if you could just reflect on two things. One, what do you think is next for the science? What are your scientists working on now that may take another 17 years or hopefully kind of less time? And two, do you think what Gilead has proved possible, what Peter just said, it's really the first time kind of in HIV where we will have a new kind of category-defining breakthrough that will kind of be accessible to those of us who live in the United States and those of us who live in low-income countries. Do you think this will be kind of a unique example or just the first of many?
It's a great question. I'll repeat what my scientists always tell me. They'd love nothing more than to not work on HIV anymore in their lifetime, because they've been at it for a couple of decades. The good news is we're at an important point of inflection for the science. I mean, finding lenacapavir allowed us to think differently about long-acting, because that is really the next field to end the epidemic. So what specifically is next? Obviously, we're firmly focused on lenacapavir rollout as a twice-a-year medicine. We've started a trial already on a once-a-year formulation for lenacapavir, which was presented at a scientific meeting earlier this year, the PK data, and it looks really quite strong. That could be available in the next couple to few years, so it's a really nice next generation on the prevention side. And on the treatment side, we have a host of about 8 other programs that we have that between now and 2033, we expect to have different types of long-acting treatment. There's still many people, some of which Peter articulated, that are not virally suppressed at all, and particularly in the developing world. And oftentimes that becomes the compliance with 1 pill once a day is just not good, or access to the healthcare system, a variety of things. So moving that to either 1 pill a week, 1 pill a month, an injection every 3 or 6 months for people with HIV is the second leg of the stool to end the epidemic. Because of course you want to stop that funnel of 1.3 million people coming in, but you also need to make sure that, and in this country alone, there's about 35 to 40% of people that are not virally suppressed. And we know that unless you're virally suppressed, you're spreading the disease. So that's the other vector you need to stop. And so we are firmly committed. We're not going to give up. We will work on another disease when we're done with this. There are plenty of other diseases. Sometimes people ask me, it doesn't seem like a very good business model, Dan, if you work yourself out of business. Don't worry, we can, this is the company that cured hepatitis C, that had the first medicine with COVID-19. There are lots of other diseases we'll work on, but I'm really excited about what's going to happen between now and the next 5 to 8 years on the innovation side.
And I certainly hope that all of those innovations will similarly be available in the rich countries
Absolutely.
And the less rich countries.
No, we'll continue to take these lessons forward.
We heard it here.
Full commitment.
Thank you, Dan. Please thank Dan and Peter. Thank you both. I'm supposed to welcome the Max Foundation and Novartis to the stage. I apologize in my enthusiasm for Dan's commitment to ensure that all of the future scientific breakthroughs that Gilead will make will be commercialized and made available simultaneously in wealthier countries and low-income countries, and so I just was awkwardly following in their wake. Oh, thank you. I don't know if you're applauding my awkwardness or my enthusiasm or just generally being polite, but thank you. So yes, could we please ask the Max Foundation and Novartis to come to stage, particularly Pat Garcia-Gonzalez of the Max Foundation and Dr. Lutz Hegman of Novartis.
Thank you so much. I'm Pat Garcia-Gonzalez. I'm the head of the Max Foundation. 34 years ago, we lost Max, my stepson, to a rare form of leukemia. He was 17 years old. So for the past 3 decades, the Max Foundation has been working to overcome the barriers and put the systems in place to be able to reach patients in every corner of the world and deliver cancer treatment. We have until now provided 600,000 years of life to more than 100,000 patients. Thank you. And as a result, our real time on treatment data shows that we have eradicated survival disparities for that leukemia that took Max. Today, if you're diagnosed with chronic myeloid leukemia in one of the 50 lowest income economies of the world, you can access the same treatment and you have the same chances of survival as somebody diagnosed in a high-income country. And the key to our success is first a relentless focus on the patient, and also in developing a human-centered health system strengthening approach that focuses on fixing the problems and eliminating the barriers around the patient to create a system that is sustainable for patients. And as we tackle breast cancer now and other high burden cancers, together with oncologists and hematologists in low and middle income countries, with global experts, with patient organizations, with ministries of health, and with the unwavering support of industry leaders such as Novartis. Today, we're proud to announce our 5-year commitment that will more than double our reach in the next 5 years. So we have helped 100,000 patients in the past 25 years, and our ambition is that by 2030, we will be reaching 100,000 patients every year. You know, a few years ago, I met a young woman in El Salvador. Her name is Maria Caridad. She was 36 years old. She was really hardworking, mother of 5. She was making pupusas at home and selling them on the street to support her children. And she had been diagnosed with cancer, and we were able to bring the medicine that she needed. And she said she will forever be grateful for the access to the medicine that was not only keeping her alive, but helping her continue to work and support her family. But she said the thing that really touched her heart was to learn that somebody in the other side of the world cared what happened to her. No one had ever cared what happened to her before. So today, I invite you to join us. Geography should not be destiny. All people should be able to face a disease such as cancer with dignity and with hope. Today, together, we can alleviate the suffering and prevent the premature death from cancer for so many. And because we can, we must, and we will for Max and for all those that left us too soon. Thank you so much.
Thank you, Pat, for your powerful words and for the extraordinary work that you and everyone at the Max Foundation do day in and day out. The more than 25 years you have dedicated to improving the lives of people living with cancer worldwide has inspired hope and dignity for patients. We are grateful for your transformative vision, unwavering commitment, and bold leadership. Ladies and gentlemen, at Novartis, we believe that access to innovative medicine should always reach the people who need them, regardless of geography or income. It is this very belief that has been the cornerstone of our partnership with the Max Foundation for nearly a quarter of a century, a collaboration that has to date enabled hundreds of thousands of patients in low and middle income countries to receive life-saving treatment. What began with the first patient in 2001 with the Gleevec International Patient Assistance Program has evolved into something truly remarkable. We now provide access to 6 Novartis medicines across more than 70 countries. Together with the Max Foundation, we have reached over 100,000 people living with chronic myeloid leukemia, breast cancer, and other malignancies, but we are not stopping here. Today, I'm pleased that our partnership with the Max Foundation will continue for another 5 years, extending our commitment to the end of 2030. Through this next phase, we aim to reach significantly more patients, expanding not just our footprint, but shared promise of hope. This milestone reflects something deeper: Novartis' unwavering dedication to staying the course in global health, even in challenging times. But we cannot do it alone, and that's why we are delighted to have partners like the Max Foundation, and it is that these partnerships will stand the test of our time, even amidst profound change. I thank you very much.
Please welcome to the stage Francisca Lucian.
Well, thank you so much, Chelsea, and thank you, Pat and Dr. Hegeman. My name is Francisca, and today I have the privilege of sharing how extraordinary leaders with ambitious and creative solutions are working to prevent and manage infectious and non-communicable diseases. Leaders who are continuing to drive breakthroughs despite an erosion of trust in public health institutions and the science that powers them, and a steep retraction of public funding. And we, as a global community, are lucky that they remain committed to this work, because even though we have seen incredible progress, we still live in a world where more than 50% of people lack access to essential health services. Non-communicable diseases account for more than 71% of deaths globally. Today, I am honored to share how our next group of commitment makers are using innovative approaches to show us what's next for improving access to treatments for non-communicable diseases. So I ask you to please join me in welcoming the following commitment makers to the stage. Ryan Hampton from Mobilize Recovery. Eric Ha from Medical Teams International. Dr. Rita Gurung from Tilgana Institute of Ophthalmology. And Kevin Shu from MEBO International. Mobilize Recovery is committing to empower students across 25 colleges in the United States with the advocacy and leadership skills, resources, and peer support networks needed to address substance use and mental health on their campuses. The Campus Surge program will equip students with the resources to drive policy changes and engage their peers on addiction, mental health, and overdose prevention. College campuses across the country may be experiencing a significant substance use and mental health crisis, but thanks to Mobilize Recovery, students themselves can begin to reverse those trends and drive lasting change on campus nationwide. And as the ongoing war in Sudan continues to disrupt education, separate and displace families, and inflict widespread trauma, Medical Teams International is committing to provide more than 27,000 conflict-affected children and their caregivers with mental health and psychosocial support. MTI will integrate mental health and psychosocial support services into its broader health work in Sudan, which includes primary care, nutrition, and cholera response. Additionally, 240 community health workers will be trained in evidence-based mental health interventions to provide care for many more years to come. With this work, MTI is giving a generation of Sudanese children the opportunity to heal from the trauma of war and displacement and grow and learn in safety. And Tilgana Institute of Ophthalmology is committing to expand access to the intraocular lens that are used to treat cataracts by launching a new facility in Hatauda, Nepal. Cataracts are the leading cause of blindness globally. This new facility will increase annual lens production from 300,000 to 1 million over the next 3 years and expand to include premium lenses, consumables, and pharmaceuticals. TIO also plans to scale its outreach microsurgical eye clinic to 15 countries and train local doctors and technicians to strengthen national eye health systems in underserved regions. With more than 30 years leading work to prevent avoidable blindness, TIO is democratizing access to high-quality, affordable eye care around the world. And finally, MEBO International is committing to provide dignity-centered chronic wound care to more than 10,000 elderly individuals across 28 countries in Asia and the Middle East. This initiative will train healthcare professionals as certified wound therapists and work with families and caregivers on wound prevention and treatment. This community-based program will also host events to provide free consultations, educational materials, and essential medical supplies like MEBO's regenerative products. As the prevalence of chronic wounds in older adults grow, MEBO is providing the education and tools to enhance equitable care in underserved regions. As long barriers like cost, access, and quality of care continue to prevent equitable health and well-being around the world, I know these commitment makers will continue to think strategically and globally to drive change. I hope we can count on all of you to join us in this work. Please give them another round of applause for the great work that they're leading. And thank you to all of you for joining us for today's session. Thank you.
This session has now concluded. Please make your way to breakout sessions beginning at 3 p.m.